It's a great pleasure to welcome you all to this educational webinar from Via Medical. My name is Herman Groepenhoff. I'm the Senior Clinical Scientific Advisor from Respiratory Diagnostics, Via Medical. I'm very happy to be involved in this kind of educational things we do from Via because I believe training is very important. I'm happy to introduce to you Aisling McGowan. She's a Chief Respiratory Physiologist at Connolly Hospital, Dublin, Ireland. She's also the co-chair of the ERS Technical Standard of Measurement of Lung Volumes, which is updated last year. So the publication she will speak about in two sessions. The first part will be more the highlights of the technical standards, and the second part on the 26th of June will be more an overview of the test performance and quality assurance. So all these quality assurance things are also inside of this extended article. At last, Aisling was also for many years the co-chair of the Assembly 9-hour Assembly on ERS, Clinical Care and Respiratory Physiology. So Aisling, please take over the microphone. I will not spend any more time of your time. So enjoy your educational lecture and I will listen to you.
Thank you, Herman. Thank you for the kind introduction, and hello, everyone. And thank you for the opportunity to present the highlights of the task force on ERS lung volumes technical standard. I'll start with my conflicts of interest of no known conflicts relation to this presentation. As Herman already stated, there's two parts to this overview. The part one today will be a brief overview of the key recommendations in the updated technical standard. And then in a month's time, I'll be covering the part two, which is a practical overview of test performance and very important new addition to the technical standard on quality assurance. So the part two session will include an overview of the practical aspects of implementing the update, which we hope you'll find very useful. How to perform a lung volumes test according to the new update. And in the new update, I'm happy to say that there's significant amount of detail describing how to perform lung volumes tests. And the three main ones are body plethysmography, multiple breath washout, and helium dilution. We'll also discuss how to review a test using the new acceptability and grading system. The reason for this introduction of the new acceptability and grading system is for consistency with the other updated standards on spirometry and also diffusing capacity that were published in 2017 and 2019. The task force also recommends new equipment quality control and a validation protocol, including the requirement for isothermal lung mechanical models for calibration and verification checks when using body plethysmographs. So we'll be providing a step-by-step overview of the quality assurance procedure, and we'll actually have some videos to demonstrate how this is done. So going back to the rationale for the task force, so the spirometry standard had been updated in 2019, the diffusing capacity standard in 2017, and the lung volume standard was last published in 2005. In the interim period, there's significant advancements in hardware and software. New research has been published, and emerging approaches have necessitated the requirement to update the guidelines to technical standard. This will therefore make it very usable and applicable as a guide to laboratory directors, physiologists, practitioners performing the test, pulmonologists, and also manufacturers who we hope will implement many of the criteria, the grading criteria. The focus of the task force is really to focus on quality of test performance and specifically to minimize variability in the measurement of lung volumes. So the key recommendations that we'll discuss today are really the emphasis from the task force on the importance of the linked maneuver for determining lung volumes after measuring FRC. In the new standard, the link spirometry maneuver will be performed by one method only. So there's only one recommended method for performing a linked spirometry maneuver. In terms of multiple breath washout, in the interim period between 2005 and 2023, when the document was published, significant publications came online relating to multiple breath washout tests, be it via nitrogen washout or via using an inert gas such as sulfur hexafluoride, SF6. The details and the requirements around that have now been included in the latest standard. So we've been fortunate enough that in the interim period in 2013, a consensus statement was published, and also in 2018, there was a specific technical standard published for multiple breath washout. The other fortunate thing was one of the task force members from the ERS, Catherine Ramsey, is also a co-author on this standard. So all of that combined, we were able to implement really relevant and important information on multiple breath washout, the technique, and how to perform a test in the latest standard. Another area of interest or improvement that we identified was in terms of helium dilution testing. In the 2005 standard, the equipment described in the document was limited to a volume-based rolling seal spirometer device. More recently, manufacturers have changed how the design of helium dilution equipment. So in the document, there's a description of flow sensing spirometry used with rebreathing bags for the measurement of helium dilution, and there's more detail on that in the published standard. One of the most significant things is the new acceptability and grading system, and I will briefly go through and describe what the acceptability and grading system looks like during this presentation. There are other areas that of interest that have changed since the 2005 guidelines, some of which are located in the supplement. They didn't make it to the main body of the standards document, but they're available as an online supplement so that you can access those at any stage as well. So significant information on GLI reference values, standardized operator comments, and the sequence of a full lung function test. There's updates on lung volumes measured by imaging and also some new techniques that have come online. There is an emphasis on pant frequency and the recommendation on measuring airways resistance using body plethysmography as well, and this is also in the supplement. So I just want to introduce the task force. The members of the task force were nominated from ERS and also from ATS. You can see that the representatives come from right across the world, US and Canada. We have co-authors from Spain, UK, Estonia, Australia, Netherlands, and of course myself, Ireland. So I've already mentioned that we have the main standard that was published in October 2023. There's also supplemental material that you can find on the ERJ website. And also a point of note is that when the standard was published in October 23, there was an error in one of the tables. So table 3 was required editing. There was a notification on the ERJ website for many months, but now it's actually been corrected in the final document. So I would recommend for some of you who would only have accessed the standard in the early days post publication, I would recommend that you go back and download a copy of the latest standard. So there was a substantial methodology that went behind this this body of work, with a significant literature search. We were very lucky to be guided by a medical librarian who is based in the US, and she's actually one of the co-authors on the document as well. With her guidance, we were able to identify all the relevant searches and information, and a significant number of publications. The next step in the process was that the task force members had to screen the documents for their relevance and their usefulness. And the documents were screened. Then for eligibility, we then identified the most appropriate documents to be used in our standardization document, but we also used manufacturer's survey, published equipment specifications, and also some of the panel had knowledge of literature that was useful that didn't show up in the original search. So how important is the determination of lung volumes? So when we're determining lung volumes, unlike spirometry, which utilizes only one methodology, lung volumes can be measured using a variety of techniques. So in healthy individuals, these approaches yield similar results, but it's not the same when we're dealing with patients who have significant lung disease. The ultimate aim of the task force was to use updated evidence to inform practitioners on how to minimize any potential within test variability and therefore improve overall test results. But determination of lung volumes measurement in the lab involves improving the measurement of all the component parts that are used to calculate lung volumes. And we know that no matter what technique is used for measuring FRC, be it body box, multiple breath washout, or helium dilution, vital capacity and one of its subdivisions, so be it inspiratory capacity or expiratory reserve volume, they are required in order to calculate what the TLC and the residual volume is. Of note, I've mentioned that in order to determine lung volumes measurements, we use 3 methods. So we have the options body plethysmography, multiple breath washout, and helium dilution. But there are other methods, and more and more, there's more publications being published surrounding these methods. However, they are extremely variable, or we don't have enough information yet. There are definitely areas of interest, and we have mentioned them in the supplementary material, and these are lung volumes assessment via imaging such as X-ray, MRI and CT, and then of course these new technologies that are measuring lung volumes such as the mini-box OEP, IST, or single breath oxygen dilution. There's again, it's a limited discussion. I won't be discussing it any further today, but you can access the relevant information you need in the supplement. So there, lots of people ask me, you know, is body plethysmography the gold standard for lung volumes measurement? And you know, yes, it's body plethysmography measures volume of all the compressible gas in the lungs. It has some really good advantages, shorter testing period. It measures all the thoracic gas in the lungs. It requires only short times to repeat the measurement. However, it does have disadvantages that we need to recognize. So it can be technically challenging to administer and perform the test. You know, patients sometimes are claustrophobic, or they might be quite large patients and they don't fit in the box. So we can't offer that as an option to those patients. And it's known that FRC can be overestimated in severe airflow obstruction. And, you know, the initial cost of a body plethysmograph is actually a significant outlay, and it does have space requirements, but I really believe over time that the cost evens out when you compare that other tests require the purchase of test gases over the duration or the lifetime of the equipment. So the other two alternatives are multiple breath washout, which measures the volume of gas within the ventilated areas in the lung, and helium dilution that also measures the volume of gas in the ventilated areas. Both of these techniques offer quiet breathing technique for the measurement of FRC. So that's a real positive, you know, so there's no major active components on behalf of the patient. However, there are significant disadvantages to these tests also. So both require longer testing times for the duration of the FRC measurement phase. You know, the task force has identified the requirement that the tests, to really appreciate that the test is valid, we really need to look at the repeatability of our measurements, just like we do with spirometry and diffusing capacity. And we do it in body plethysmography because we always repeat the measurements. So we can look at the variability, and we can look at the validity of the measures that we're actually going to use on the patient to report the patient's results. So we have recommended that a minimum of 2 tests are carried out for multiple breath washout and also for helium dilution. So there will be the requirement for a significant extra time to be able to comply with that requirement. With multiple breath washout, there's significant risk to patients who are ventilation sensitive. So if they're on oxygen, you know, it can cause trouble for some patients. In terms of helium dilution, we know that the test can be underestimated in obstructive lung disease, but that's the same for multiple breath washout as well. So what are we actually measuring? So everyone's familiar with this chart. It's our bread and butter when it comes to lung volumes. So what we're actually measuring is we're measuring at the beginning of the test, we're measuring the tidal breathing. We're making sure that we have nice, stable baseline phase. And then what we want to measure are 2 things. The 2 measurements that are key to lung volumes are vital capacity measurement and also the FRC measurement. Now, so let's look at the measurement of the VC first of all. So regardless of the technique used to measure the FRC, so we have three methods, but regardless of the technique, one of the subdivisions of the vital capacity, be it the inspiratory capacity or the ERV, will be used to calculate TLC and RV. So we know that it's so important that we have a valid vital capacity measurement, but it's also important that we know that the vital capacity matches the baseline phase and it's matched to the FRC level during the test. So in the 2005 guidelines, what was presented to practitioners was that they had a preferred method of performing the test. And then if the patient couldn't comply with that, there was an easier alternative method. So the preferred method was measurement of FRC, and then immediately post measurement of FRC, you had to perform an ERV maneuver and then an IC maneuver to TLC. So that was the preferred method, but then the easier optional or alternative method was to ask the patient post FRC to perform an inspiratory capacity maneuver. So the inference there was that the alternative maneuver is somehow easier on the patient. So with that in mind, this task force, we reviewed, keeping that in mind, what were the significant differences between the preferred method and the alternative method when in our approach, keeping in mind that we still require a repeatable and a repeatable measurement of vital capacity. So we reviewed the literature, and what we discovered was in all the publications, there were slight differences between the preferred method and the alternative method. However, they were not statistically significant. So our preference then, or decision was that we would choose the alternative method as the one standard method going forward for performing the test, because this method is expected to be the most achievable by most patients if it is easier or more natural. So a patient is, using the example of a patient having body plethysmography carried out by lung volumes by body plethysmography, they have their panting maneuver with the closed shutter, and then the shutter is opened. It's the most natural reaction for the patient to breathe in once the shutter is open. So so all of the evidence was pointing at the choice of standardizing this procedure to include an IC maneuver immediately post FRC, and to have it linked then to post IC, that they continue then and do a slow vital capacity maneuver, expiratory vital capacity maneuver. So what we have recommended is that initially there's a stable pre-phase end tidal volume measurement. So you have tidal breathing at baseline to establish that the patient is breathing at their FRC level. And then we perform the FRC measurement, be it by body plethysmography or multiple breath washout or helium dilution. And then immediately post, we will ask the patient to perform an IC maneuver to TLC, and then continue in a linked manner and perform a slow expiratory vital capacity maneuver to residual volume. Now, it requires coaching in order to avoid an overestimation of the residual volume. So on the right-hand side, the bottom of the screen, we can see an example of, we have nice stable pre-phase measurement here for a healthy patient, and we have a patient with airflow obstruction. Okay, so we have a nice stable baseline phase. Then the patient is asked to inspire, do an inspiratory capacity movement maneuver. However, the patient is not coached to perform a slow expiratory vital capacity maneuver. And what we see is in the healthy patient that the EVC is larger than a forced vital capacity maneuver in a patient with airflow obstruction. So what happens there is, in the patient with airflow obstruction, the airways collapse, they have dynamic gas trapping, and what happens is it results in an overestimation of the residual volume. So it's so important to be aware of that and to make sure that during this linked vital capacity maneuver, we coach the patient to blow out slowly and completely to residual volume. We've also introduced acceptability and usability criteria for spirometry for the calculation of residual volume and TLC. So this is new, and it's broken down into 3 different categories. So we have an acceptable category, a usable category, and then we have the last, which is not acceptable or usable. So it's a reject. So this category would not be reported, even considered for reporting. So for the spirometry maneuver, acceptability criteria after FRC measurements. So acceptable would be a linked spirometry. So for anyone aged over 6 years old, once you perform the linked spirometry maneuver, the operator will assess the SVC that they measured, and ideally, one of the first tests that the patient would have been a spirometry test when they come into the lab. So they would have the force vital capacity from that measurement, and they can use it to refer to in order to compare with the SVC. So the SVC in the linked maneuver should be greater or equal to the pre-test FVC minus 150 mils. And then there's a different criteria for children under 6. A usable in the usable category, the criteria would be any of, so an unlinked spirometry with a multiple breaths washout test or a helium dilution FRC measurement. So, but it must have a stable pre-phase end tidal lung volume. So the important thing here is you can only accept as usable a test, an unlinked spirometry that's performed with a multiple breath washout or a helium dilution test. And the reason for that is that body plethysmography, the FRC measurement stage of that test is very short, it's 2 to 3 seconds. So it's not unreasonable to expect a patient, because you can repeat it and do it again several times. It's not unreasonable to expect that the patient can comply with a linked spirometry maneuver during body plethysmography. However, in a multiple breath washout test, the FRC phase can go on for several minutes, and same for helium dilution, it can go on for several minutes, especially when the patient has severe airflow obstruction. So sometimes those patients can get very tired, and they would perhaps perform a submaximal spirometry in that case, and therefore you can do an unlinked maneuver for those patients. So in that case, the criteria for comparison of the slow vital capacity with the forced vital capacity is slightly looser. It's FVC minus 250 mils. And again, there's different criteria for children. I want you to draw your attention to the below the table. You'll see that there's an important statement. So if during the test session you haven't performed a force vital capacity, the statement says if force spirometry is not performed in the same session with lung volumes, an alternative is to require that at least 3 measures of vital capacity that meet the ATS ERS acceptability criteria for within maneuver evaluation are obtained, and that the largest of these vital capacities is a substitute for the FVC in the table. So what they're saying is, instead of doing force vital capacities, repeatable force vital capacities before you do your lung volumes measurement, you could perform slow vital capacity measurements as one of the tests before you perform lung volumes. Then you have a set of repeatable values that you can then substitute instead of the force vital capacity when assessing the test for acceptability and usability. So the definition of for stability is, so it's defined as 3 or more tidal breaths with the difference between the maximum and minimum end expiratory lung volume within 15% of the tidal volume. And that's very important because we're looking at that stable pre-phase values, that it is repeatable, that it's within the 15% as part, especially when we're looking at the usability. We want to make sure that we're evaluating it properly. Other issues that can affect a measurement and cause variability would be the sequence by which you actually perform the tests. Now, the laboratory director would usually guide this process very well, and their knowledge of the technology that's been used, the training that they provide to the practitioners carrying out the tests would be of a very high standard. But it is very important to be aware of the tests that you're actually performing. Which test? Is it body plethysmography? Is it nitrogen washout? Is it multiple breath washout? Which test you're performing and what sequence you need to perform them in. For example, if you are performing nitrogen washout with 100% oxygen, you always make sure that you perform the diffusing capacity test prior to the nitrogen washout test. So that's very important. In terms of reference values, very important again in terms of interpreting the results. The task force have agreed that the published GLI values are what should be used, while acknowledging that they really are strictly covering individuals of European ancestry. Mind you, the GLI group are always updating their library of data, and so it's something that you just need to note, that we do validate the use of these values. General test preparation can have a huge influence on the results as well. So there's a section in the guideline with regard to patient preparation, suitable mouthpieces, sitting position. We offer advice on alternative measures for measuring height. During body plethysmography, it's so important to support the cheeks during measurement. Making sure that you're coaching the patients appropriately, and that the patients are allowed to become familiar with the technology that you're using as well. So In terms of measurement of FRC using body plethysmography, there is a detailed description in the standard. It's a step-by-step description on how to manage the patient before the shutter is closed and even when before the cabin is closed. Details. The details are all in the standard. One of the main things would be in this standard that we focus on the breathing or the panting frequency. So there's a strict focus on the panting frequency that's recommended should be between 30 to 60 breaths per minute. And we should certainly avoid panting of greater than 90 breaths per minute, especially in patients with airflow obstruction, because it will cause gas trapping. And then panting less than 30 breaths per minute with some systems can cause problems, technical problems with the body box. And then, you know, once we perform the FRC maneuver, we want to make sure that we perform a linked maneuver as I previously described. We also ask that the practitioner or operator that they review the placement of the panting loop tangent lines. This is very important, and that they also would check the switch-in level comparing the VTG with the FRC pleth on the tracing, and that a technical comment should always be applied, commenting on test performance and test quality. So there should be 3 to 5 technically satisfactory panting maneuvers. The patient then should perform their linked maneuver also. Here's a slide just to reiterate the importance of checking the switch-in value. I am aware that many manufacturers will correct for this, but it's very important just that you understand that sometimes if the patient is switched in too early or too late within the breathing cycle, it can have an effect on the measurement. So the acceptability criteria for FRC measurements by body box. So again, the classification is broken down into acceptable, usable, and not acceptable or usable. And the main thing that they describe is again the stable end tidal lung volume. And during the shutter closure, the closed panting maneuver, the avoidance of any thermal artifacts or drift, adherence to the recommended panting frequency of 30 to 60 hertz, and especially be cautious when we know that a patient has airflow obstruction that we have detected on spirometry. And then, we have our usable criteria, and we also have our non-acceptable or usable criteria. So again, our focus is on that pre-phase baseline tidal breathing checks and on the panting and breathing rate during the shutter maneuver. So we've also introduced a grading system for the 3 measurements. So we have this grading system has actually not been validated. We look forward to some publications, some work done on this to validate this process. And I haven't had an opportunity to have a look at what was presented at ATS, but I'm hoping that something has been done because we really need some research to support or even to critically review this proposed grading system. The grading system is based on grades A to E, and then U for usable and F for fail. So the grading of the overall test is, the advantage is that will really support people in their reporting capacity of the test and reviewing the quality of the measurement. What we've put in the standard is that we hope that the manufacturers will take this on board and that they will implement this in the future. But especially, we're especially interested in this validation work, if at all possible. It's a combination, the grading is a combination of the number of FRC measurements combined with the repeatability of these measurements. So there's a minimum of 3 FRC acceptable measurements within repeatability range of 5%. And with that, we have to have greater than 3 linked SVC measurements that are compliant with the 2019 standard. So you can work your way down through the table here and look at the different grades to assess the values. What I will do is in the part 2 of this session next month, I will have some case reports and I will have some explanations, and we will use the grading system to help you understand better. So in the document, there's very nice descriptions of how you perform the test, okay? So as I mentioned earlier, we were very fortunate for multiple breath washout that we had the consensus statement, we had the published task force document, and also an expert colleague on our own committee that could guide us in the content that we have put in the document. But the key points would be, check that the patient is suitable for the test. If they've perforated eardrum, they should wear an earplug. There should be a quiet, stable breathing phase at the beginning of the test, the pre-FRC measurement phase. It should be 30 to 60 seconds. Then we would switch the patient in at or near FRC. The patient would be instructed to breathe regular tidal breaths without sighs, cough, or apnea, and that's really important, okay? So we want to emphasize that it's regular tidal breathing or just above regular tidal breathing. So if it's slightly deeper breaths, as long as it's consistent across during the entire FRC measurement phase, that is acceptable. The washout is complete when the end tidal tracer gas concentration, so is below 1/40th of the initial starting concentration for at least 3 consecutive tidal breaths, and that's very important. And that vital bit of information came from the consensus statement and the task force document. And once the FRC is complete, the patient is instructed to perform a linked SVC maneuver. So ideally, you would measure 2 technically satisfactory measurements. The picture on your right shows a nice acceptable measurement. You can see as the test progresses, the nitrogen level drops down to a level, and if it's consistent with the criteria, it'll be 1/40th of the initial nitrogen concentration for at least 3 consecutive breaths. Since you're going to measure 2 tests, a minimum of 2 tests, a waiting period of at least twice the washout test time is recommended between maneuvers, and longer waiting periods may be required if a patient has severe obstructive disease or bullous disease. And the mean technically acceptable results that agree between 10% should be accepted. So in the interest of time and the fact that I'm going to go through this in part 2 session, in the supplement, we have actually provided you with examples of traces of acceptable, usable, unusable, and we have detailed descriptions to support why they are acceptable usable and unacceptable. So the acceptability and grading criteria, capacity measurement for multiple breath washout, again, it's in 3 categories. It's acceptable, usable, or reject. And again, I will leave you to focus on this. In the interest of time, I'm moving on to the helium dilution technique. So in this part of the standard, the 2005 version of the document only described a volume displacement spirometer technology. So many manufacturers have provided equipment, and it's still in use in laboratories that doesn't comply with that description. So what we've done is we've included the more frequently supplied equipment description. So this would include a flow sensing spirometer with a rebreathing bag, and a full description of how that technology can be used and how it operates is provided in the new standard. Again, standardization of the technique is important. It's very similar to the description that's provided for multiple breath washout. So it's pretty consistent in its description. For helium dilution, we also recommend at least 2 technically satisfactory measurements, and the wait time between the 2 tests must be twice the washout time of the initial test. When there's one trial performed, for example, it should, when there's more than one trial, and we are recommending that you do 2, that you should report the mean value, and it should be agreed within 10%. Now, what's useful here is because of the similarities between the 2 techniques, the grading system that we have proposed for both MBW and helium dilution is actually the same. So the acceptability criteria, usability, or the not acceptable or usable are actually the same grading criteria. And the here, so we are recommending in terms of grading, it's the same. It's A to E, U for usable, and then F for fail. So it's in terms of FRC measurements, we have a minimum of 2 acceptable measurements, with a repeatability of within 10%, and the linked maneuvers during those measurements, the SVC should have a minimum of 2 acceptable values according to the ATS ERS standard. And again, you can review yourselves grade B, C, D, etc. So operator comments are very important in the other standards for spirometry and diffusing capacity. Operator comments were proved to be very useful, and standardization of the comments is strongly encouraged in order to promote standardized reporting and to meaningfully guide interpretation. So the report grade of the test with the number of maneuvers used and the degree of repeatability is very useful in terms of an operator comment. So for example, a grade A measurement, 2 acceptable maneuvers with an FRC within 5% is extremely useful when somebody is following up and reporting on the test. So technical criteria and comments on whether the test didn't meet the grading criteria are also useful. a statement of explaining why one test was acceptable or usable and one was not, comments on any difficulties the patient encountered, whether the patient was claustrophobic and therefore the measurement couldn't be attempted for plethysmography, and maybe an alternative method was used instead of plethysmography. So operator comments are strongly encouraged. So going back to the supplementary material, you can see on the right-hand side, this online material is quite extensive, and I would highly recommend that you become familiar with it. There's also new equipment software validation Excel sheet that's provided, and I'm going to discuss that in the next session. I'm going to briefly just bring up, because I'm really running over time, unfortunately, but that in the supplement, so the topic of airways resistance kept coming up as a discussion point amongst the task force, because especially when we were discussing body plethysmography, because airways resistance is also measured by body plethysmography, and it's an important measure, it's a useful measure, it's a very sensitive measure, and so it had to be discussed. Now, the issue with airways resistance measurement is that there is no standardization document. There is no standard. So the first thing I would say is that there is a need. There is definitely a need, and we would call for the development of an evidence-based standard in order to improve the quality and the performance of airways resistance tests. The information in the supplement is not intended as a technical standard, however, and it's based on the experience of the task force members, and it's not based on a systematic review of the literature. So the task force emphasised the need to separate the measurement of airways resistance from the measurement of lung volumes by body plethysmography. So they should be measured independently and not together, because the main reasons would be the panting frequency that we use to measure airways resistance is different to what we would use for measuring lung volumes. So what we're doing there is, by measuring it together, we're introducing errors and variability into the measurement. So the other issue would be increased time on the mouthpiece performing the airways resistance test as well as the lung volumes test would increase the time on the mouthpiece and may not be tolerated very well by patients. It's very important that we separate out those measurements. So it's a strong recommendation from the task force group. There is also a table 6, recommending further criteria for the measurement of specific airways measurements. And I suppose the most important thing is that measurement of airways resistance must not be performed during the same maneuver during the measurement of lung volumes, because the optimal panting frequencies are different, and the increased time in the mouthpiece increases the opportunity for leak and can compromise accurate measurement of lung volumes. So it's totally against what we want to do in the first place. So in terms of the measurement technique, we establish a stable baseline. We instruct the patient to pant with the shutter open, so therefore the vocal cords stay open at quite a fast breathing rate of 1.5 to 2 per second. The rapid and consistent panting rate ensures full opening of the vocal cords and reduces variability. To measure the lung volume associated with the ERS resistance measurement, once the open shutter loops are acceptable, so usually we try and measure those within as short time as possible, we follow with a closed shutter and performing the panting at between 30 and 60 breaths per minute. What we do then is we take the median value of up to 5 technically acceptable loops, and the aim is to report the mean of the results from at least 3 acceptable maneuvers. And all that information is contained in the supplement. In terms of reference values for ERS resistance, the availability of reference values for ERS resistance parameters was limited. The Arena Steenbroeken did a significant amount of work on this, reviewing the literature. And what was discovered was that there was, it was limited. A lot of the publications were limited to relatively small sample size. And that information is actually contained in the supplement as well. So lastly, and apologies for going over time, but I would like to acknowledge my co-authors and all their hard work working on the updated lung volume standard. My colleagues that work here in Connolly Hospital has supported me when I was, especially towards the end, when myself and my co-chair were trying to finish up finishing the document and sending it off for publication. And then lastly, to thank VIAR for sponsoring me and getting the opportunity to present this at this webinar. Thank you very much.
Thank you, Aisling, for this excellent presentation. And for your information, you stayed within the time, but we have
okay.
a kind of 20 nice questions.
Okay, good.
And I apologize. I think we should take another 15 minutes and then I will stop and try to answer most of the questions. And again, I'm already looking forward to the second webinar on the 26th of June. And then, of course, I'm sure Aisling will also cover the questions not be answered today. But I will start very quickly reading the questions for you. If a linked slow vital capacity cannot be achieved during FRC PLET, can we still use an unlinked one? Because sometimes it's not always possible. This is the question.
Yep. It's not recommended. Again, to reiterate, there's 3 significant phases to the measurement. So the initial phase is tidal breathing at FRC. So if it's in the body box, you make sure that the patient their shoulders are relaxed, that they're supporting their cheeks. In the initial stages of the measurement, they understand that the shutter is going to close for 2 to 3 seconds, that they're going to breathe at between 0.5 hertz and 1 hertz, so 30 to 60 breaths per minute, just for 2 or 3 seconds. Then the shutter will open and the patient will then they're naturally going to want to breathe in. So they naturally breathe all the way in. You coach them to breathe in to total lung capacity, and then you coach them to steadily, slowly blow all the way out. So from experience, over 33 years working in the area, if you prepare the patient and discuss with the patient, most patients will be able to achieve that. They will be able to achieve it if you put the effort in and you put the time in. So if it's not successful once or twice, try and explain again, try and do it again. What I would say is these are standards. They're what's recommended. It's not really a guideline where you can be really flexible. But what I would say is your laboratory director, who would be very experienced, or yourself, you can use your own judgment. What's recommended is if the spirometry is not repeatable, and it's an unlinked maneuver, that you should just report the FRC measurement alone. That's what we're recommending, okay? But what I would encourage you to do is try to get the measurement and encourage the patient to do it, or bring them back another time and repeat the measurement. But in the meantime, you should have reproducible FRC measurement, and you should be able to report that. I hope that answers your question.
Yeah, okay, thank you. Strange if it comes from me. Please keep your answers short. I'm also not good in this. But it's all over, of course. Again, I cannot leave it to give some. You should not throw away the data, but I understand you are from the guidelines, and you will not have the grading then. You will have a zero grading, but of course people should not throw away the data. It's the same if you have if you didn't do the preferred method, you do the ERV method, you will not have the grading, or should you have a grading? Is it for next time for your examples?
Well, again, we only recommend one method, so there won't be the preferred method. It'll be the one method, which is the IC.
And the only one method get grading.
Yeah, only one method. Yeah.
Sorry, now I take too much time.
Yeah,
how much time do the shutter has to be closed?
Again, it's typically between 2 to 3 seconds, but I know from experience that, you know, I always like to have full control of that shutter. And again, you know, an experienced physiologist will always intervene, especially if a patient is struggling towards the, you know, they might be okay for 1.5 seconds or 2 seconds, but typically we're not saying that the shutter should be shut for 2 to 3 seconds. We're saying typically it's shut for that length of time. So you should have full control of how long the shutter is, as long as you get enough measurements within that time based on the breathing frequency of 30 to 60 breaths per minute.
So if I understand you well, and I totally agree, you manually open the shutter. You put it on something and you prefer to press some kind of functional key to open it yourself. Is it useful to have a previous spirometry to compare? So the sequence first to do spirometry, maybe some training, or I don't know.
Yeah, well, it depends what the pathophysiology is. So, you know, patients, their lung function can change. Some patients, it's very consistent. Some patients, it's extremely variable. So if you're using a measurement from 6 months ago, you cannot rely on that spirometry, say in a patient with variable airways disease, that's a reliable measurement. So if you're concerned about doing a forced vital capacity, well, then it's mentioned in the standard that you can use the alternative of your initial test can be 3 repeatable slow vital capacities. And I know in the UK, of colleagues in the UK who advocate for performing a slow vital capacity over a forced vital capacity before they perform a lung volumes measurement. So you do have the option to do that if you don't want to perform a forced vital capacity.
Would it be acceptable to allow the patient, after opening the shutter, to have a few tidal breaths and then perform the IC maneuver?
That is possible, as long as the baseline is consistent with the pre-FRC stable tidal breathing phase.
Yeah, and no leakage, obviously.
Yeah, and no drift. We don't want any drift upwards or downwards. You know, continuous drifting down or continuous drifting upwards in an upright fashion would not be recommended either. So yes, I would say that that's fine. 1 or 2 breaths is fine, as long as it's the baseline does not shift significantly upwards or downwards.
Yeah. When you say the expiratory vital capacity after the IC maneuver should be not forced, you mean it cannot be forced, right? I just read what it is. We should ask patients to exhale at will without any effort beyond what is necessary to reach residual volume.
So I gave you I showed you the example of when people don't ask the patient to perform a slow vital capacity. So in a patient with airflow obstruction, it'll cause airway collapse and gas trapping, and so you're not going to get an accurate residual volume measurement. You can't calculate it properly because they have there's too much gas trapping.
In young patients, in children, when they perform pulmonary function testing, I see you can also read the question. The FVC is larger than the slow vital capacity.
Yep.
Is it valid to use the large vital capacity measured? So I think they struggle. Which one should they use then? Because
I would definitely use the largest vital capacity because it says greater than in the description. It says greater than the FVC. Okay, so whichever is greater is what you use.
Yeah. No, and I think you explained this, but this is very you can answer this very quickly. So the patient is not going straight to ERV and residual volume after FVC. No, this was the previous recommended one.
That's the previous recommended one. I can't. Can you just read out the question for me there? Sorry, I've lost track of where I am.
I already deleted from that. But
sorry.
So the patient is not going directly to ERV residual volume after FRC.
Okay, well they shouldn't. So you perform your baseline, then you perform your FRC measure, and immediately post FRC measurement, you encourage your patient to breathe all the way in to total lung capacity. You're not performing an ERV measurement anymore. That is not recommended. Then in a linked fashion, so it's a continuous measurement, your inspiratory capacity and then your full expiratory vital capacity to residual volume. So it's a linked measurement.
Yeah. And again, you will highlight this in the second webinar again.
I will.
And I learned if you do this the other way, because I was used to do this, I will not get any grading anymore.
Yeah.
Clear. How do you support the cheeks? Never quite heard it spoken this way and not sure how to do that.
Yeah, okay. Well, if I'll demonstrate then. Okay, so the big thing with patients is they should sit quite straight in the chair in the box. And the other thing is you have to make sure that their shoulders are relaxed, that their FRC is actually at the true level. So it's always a good idea to say to the patients, relax. And they actually naturally breathe out. So they will shift down their FRC. It'll be their normal natural FRC line. Then what they should do is just get the palms of their hand, and they should, obviously the best type of mouthpiece is, you always use filter, but you would always attach a diver's mouthpiece, typically a rubber mouthpiece, so it has that extra seal inside the lips, so it'll ensure against leak in case the patient's mouth opens, because it's not just the cheeks, it's their lips. Holding the cheeks will not stop your lips opening. So that's very important as well. So they sit straight. The main thing is they don't have their elbows in the raised. They have them by their side. They hold their cheeks like this. So it's really the fleshy part. Like I have quite, as you can see, fleshy cheeks. So you don't want to measure the compliance of those cheeks as part of the measurement, because we're measuring resistance compliance. So as well, it can affect the measurement. So what you want to do is hold the cheeks with the arms rested, just relaxed at the side and with their shoulders relaxed. And that's what they do, and they stay on the mouthpiece for the duration of the test. I hope that helps.
Yes, this helps. I was already happy with your explanation, but I'm totally agreeing that they should use a scuba dive mouthpiece and not only the filter. Thank you. Should we be using the TLC and residual volume when looking at consistency and acceptability, like validity, or FRC and slow vital capacity? So if you do quality control, which parameter should you prefer?
well, in the table, it's FRC and Slovak capacity. So that's the only acceptability criteria that's provided.
Okay. If your body box does quiet breathing method for body plethysmography, this is not longer recommended by guidelines. Quiet breathing.
Okay, so this was also an area of debate, and I'm glad somebody has actually brought it up in a way. So some companies will use an algorithm to correct for low panting rates, okay? But that is not consistent across all manufacturers, okay? So the other thing is that the data supporting low panting rates is when you check quality control values in a group. There was a publication in 2021, I believe, at ERS, and what they did was they looked at airways resistance, for example, in the body box at low panting frequency versus panting frequency between 30 and 60 breaths per minute, and the CV. So the confidence and the variability was much higher in the same healthy individuals when the panting rate was at a low panting rate versus between 30 and 60 breaths per minute, or higher. Actually, was I think it was higher value. So again, as a task force, we had to review the literature, look for evidence to support what we said, and the evidence for low panting rates is just not there yet, because it tends to be very reliant on company-specific algorithms. So as a task force, we just haven't there wasn't enough evidence to actually comment on that. And in next month, I'm going to talk a little bit more about quality assurance, and that will be part of the presentation.
We still have a few minutes left. It seems a lot of questions open, but for your information, I'm happy there are also a lot of thank you for this excellent presentation, for your knowledge. So I tried to do one or two extra questions, last questions, and again, we will read the questions and try to capture the open questions next time. With most veterans, I can get FRC and slow vital capacity at the same time. I can't get them back to baseline. What's the opinion on getting them separate? So it's all about linked, yes or no, I think.
Well, it's only an issue if you perform the test the way we have described. There shouldn't be a shift from the baseline. So you have your stable baseline, you perform the FRC measurement. So what test are they talking about? Did they mention whether it was body box or whether it was nitrogen washout or what it was? But immediately post FRC, regardless of the technique you use, you immediately ask the patient to breathe all the way in. And then again, it's a slow vital capacity. So even in the most obstructed patients, they should be able to exhale to residual volume. I think, if you're talking about a shift in baseline, you must be getting the patient to breathe again between the FRC and the vital capacity maneuver. So it's not what we're recommending. So what I would recommend is they try what we have suggested, and they might see a difference.
Yeah. Last two questions. Yeah, I don't know. I like this question, but it's not. Any tips how we might help medics understand grading systems as we still struggle with set scores versus percentage of predicted? Sorry to ask you this question after all these years. So I think I understand the question, but yeah, I'm happy you have to answer it.
Yeah. Well, I suppose your Z scores are really interpretation of the measurement and reporting of the measurement. It's not performing the test. So this task force wouldn't cater for that, or wouldn't. That's not a question we're answering. This task force was all about improving the quality of the measurement rather than looking at the improving the quality of the knowledge of the doctor to interpret the test. Um, um, yeah, I mean, it's the grading. What I would say is, in the document, we have recommended that the companies try and implement it as standard. So basically, once that is done, it shouldn't be difficult for the doctors to understand because the work is actually done.
Yeah.
Currently, because it's not built into the software, yes, it is a challenge. And it's not just a challenge for medics, it's a challenge for lots of people, because you have to print off all the tables and you have to have them beside you when you're evaluating. Hopefully, we find once the standard is published, it takes up to 2 years for feedback to come back on whether the criteria is working or whether the grading is working, or feedback to manufacturers as to whether the grading is actually that they worked very hard to implement is also working. So it takes up to about 2 years for that feedback and people to start publishing and, sending letters to the editor in response to a lung volume, in particular our lung volume standard. So I hope that's actually answering your question. I'm
No,
not.
I think you
Yeah.
answered it perfectly, especially for me being from Vayer, that you recognize as one of the authors that it is maybe, I will not say it's a large job to have this publication, but to get it implemented. And I saw in all of the attendees, of course, colleagues of mine who have to implement it. But you say send a letter to the author if you have questions, or reach out to you personally. But I'm already happy with all of your nice presentation. I think you did an excellent job. And also, I think it's important that you make a point that it is not that easy for all manufacturers to get it in, and that you as an author even wonder, you say it would be in perfect circle if everything works. You have a nice publication,
Yeah.
and the manufacturers can get it working for the people, and we understand each other. And again, thank you for this nice presentation. We go through the open questions, but I think you covered most of them. Looking forward to the second one, which will be a little bit more practical.
Yeah.
Thank you. Thank you
Okay.
all for still attending. There are still more than 500 people in the meeting. Thank you for this. Apologizing taking 20 minutes, but I think the last part, this interactive part, is always as important as the first one. So thank you. Looking forward to the next one.
If there's Herman, if there's any questions that haven't been answered, I'm happy to answer them afterwards, and I'll reply to people. Okay.
Yeah. But
or the start of the next session.
No, the good thing is we captured them all, and I will share them with you. There are still 40. So
oh, really? Oh, okay.
now again, half of them say you did an excellent job. Okay.
Okay. Thank you. Thanks.
Nice way to end this session. See you next time. Bye.
Thank you.